Hello, everyone. This is Dr. Kamal again, and this is the second part of the DKA HHS. In the first part, we talked about the pathophysiology, the diagnosis, differential diagnosis, signs and symptoms. Now we'll talk about the workup and investigations and also the management of DKA and HHS. First of all, we need to know that whatever workup we'll order, will order simultaneously and will not delay the treatment for the results. Just with point of care beta hydroxybutyrate, point of care um, glucose monitor, we can basically diagnose these two conditions, and the rest of the blood work can, um, you know, get back to us, but this shouldn't delay the treatment. So initially, what will like just to classify or some organization for the workup, there is some workup in the blood, some workup in the urine, and some other workup and investigations and how to monitor these patients after starting the treatment. So of course, we'll need BMP or CMP to look at the glucose, the different electrolytes, the kidney function. We'll need ABG or VBG for the acidosis part and also the compensation. We'll need to check the blood beta hydroxybutyrate, which can be point of care, and if it's above 3, that can be diagnostic. We'll also get a CBC because, as we said, number one trigger or like the most common cause trigger for DK and HHS will be infection. So in the CBC, you are expected to see leukocytosis, and this is mainly stress leukocytosis, doesn't mean there's an infection. But if you see fever, fever is not part of the DKA and HHS. So this should warrant us for some kind of ongoing infection, and this will have different workup to look for the source of the infection and to treat it. We'll also need a hemoglobin A1C because it will reflect the glycemic control. We sometimes can look for lipase, some kind of like pancreatitis can happen, and this can lead to DKA. If you are suspecting fever or some ischemia or bleeding, you can get lactate as well. And of course, if there's a fever, suspecting an infection, you can get blood cultures. In the urine, you can get urine analysis with microscopy. You are looking for infection like urinary tract infection. You can look for the glucose and ketones, but if you have the serum glucose and ketones or beta hydroxybutyrate, this is less important. Again, urine culture, if UTI, sometimes aglycemic ketoacidosis can be pregnancy triggered. So if someone in the reproductive age or childbearing age, you can get pregnancy test because this can be a trigger as well. If there's a hyperkalemia, especially if the potassium is above 7, you need to get an ECG to look for any changes in the EKG that could be caused by hypokalemia or hyperkalemia. Again, if there's fever or you're suspecting some kind of infection, and pneumonia could be a possible infection, you can get a chest X-ray. And also, especially in the HHS, you need to calculate the osmolality as well. And if there's hyponatremia, to correct the sodium for um, the hyperglycemia. While ongoing treatment, these patients need ongoing monitoring, whether in the ICU or on the floors. They need hourly glucose, and this can be just bedside glucometer. You don't need to send it to the lab. Beta hydroxybutyrate, again, that's a blood test, and you can get it every 2 to 4 hours, and you are targeting beta hydroxybutyrate below 1. And again, remember previously beta hydroxybutyrate used to have only diagnostic value for DKA, but now you can even monitor the progress or the resolution of the DKA by getting serial BHBs. Then again, you'll get BMP every 2 to 4 hours. Number one, you're looking for the acidosis, the bicarb, if the acidosis is getting better. The potassium, whether you have hypokalemia, hyperkalemia, normokalemia, or normal potassium, because this will need some adjustment to the insulin and they might need some potassium supplement, and also the anion gap monitoring. You need also VBG or to check the pH. If you have arterial line, you can get an ABG every 2 to 4 hours until resolution. These patients also, they are losing a lot of fluid between the polyuria and vomiting, and you are giving a lot of fluid as well. So you need to monitor the fluid input and output. Um, so might need to put a Foley to get more accurate urine output. These patients also will need neurochecks, GCS every 1 to 2 hours, especially in the moderate and severe cases that can lead to coma, or sometimes if the GCS below 8 or they are severely altered, they might need intubation as well. And of course, vital signs. You need to get continuous monitoring of vital signs to look for tachycardia or hypotension or increase in the respiratory rate or anything like that. And this is mainly will be in the ICU setting. Very important note here that you can see leukocytosis in DKA, and this is mainly because of stress response. But DKA, usually you don't see fever. So if you see leukocytosis, that's okay. If you see a fever, usually you need to look for signs and symptoms of infection, get blood cultures, get urine infection test, get chest X-ray to look for pneumonia, and antibiotics if needed. So again, as any emergency, because we agreed DK and the HHS are emergency, so in any emergency, the most important step is the initial stabilization, which is the ABC approach, airway, breathing, and circulation. So this will come first, then priority of the orders that will give or manage the patient IV fluid come first. Then we check the potassium. Depending on the potassium, we see if we'll start insulin first or we can replete potassium first. So airway and breathing, we need to assess the airway, and sometimes these patients will need intubation, but that's rarely because DKA, usually you can manage it and you can treat it before these patients decompensate. We'll monitor the respiratory rate. Again, Kussmaul breathing is compensatory because you have metabolic acidosis. So the compensation will be respiratory alkalosis. Respiratory alkalosis mainly to blow off or get rid of the carbon dioxide. So you need to increase the respiratory rate. So this is usually a compensation. So don't try to suppress that. If there's intubation needed, you will need to provide hyperventilation. Remember, the normal compensatory mechanism is to increase the respiratory rate. So if you put these patients on mechanical ventilation, you will need to increase the respiratory rate and cause some kind of hyperventilation. Um, and if you're intubated and put them on mechanical ventilation, you will need to target the PCO2 according to Winter's formula. So Winter's formula can calculate the compensatory PCO2. Let's say if according to Winter's formula, the CO2 should be 30. So when you put these patients on intubation, you should put this in mind to target PCO2 um, to compensate lower PCO2, higher respiratory rate to compensate for the metabolic acidosis. Sometimes the problem with intubation, sometimes it will be very high risk because usually these patients can compensate pretty well. And when you try to sedate this patient, give neuromuscular blocker or just the intubation process, this can slow down the respiratory compensation. So usually intubation DK is very high risk, so try to avoid this um, as you can. Um, so that's the airway. We want to make sure they have patent airway. and they are breathing fine, right? Um, we want to make sure um, we want to make sure that they already having good respiratory compensation, and if we intubate, we make sure to maintain this hyperventilation process. Second, blood pressure and circulation. These patients will need two large bore IVs. Why? Because these patients will need insulin drip, they will need IV fluid, they need frequent labs, they will need some electrolyte replacement. So you need really good IV access on these patients. And again, begin fluid resuscitation immediately. Assess degree of dehydration. So usually these patients are dehydrated. The severity of dehydration is way higher in HHS, usually between 9 to 12 liter deficit, but in DKA, the dehydration deficit is usually 3 to 6 liter. If there is any hemodynamic instability, like they are in shock, for example, if they are severely dehydrated HHS, you need to um, stabilize those patients, whether with IV fluid, if they need pressure, whatever they need, you need to stabilize before giving insulin. So always stabilize, give IV fluid, then let's talk. Let's talk about insulin, let's talk about electrolytes, let's talk about labs, let's talk about everything else. But stabilize, give IV fluid. Again, if they're in shock, IV fluid, they can respond to IV fluid, but if they don't respond, you'll need to start vasopressors, and norepinephrine will be the drug of choice here. We need to look for the electrolytes. That's why you are getting the BMP, also the magnesium and phos. So we need to look for the potassium before starting insulin, because insulin by itself can decrease the potassium, and they can be severely hypokalemic, putting them on higher risk for arrhythmias. So the normal potassium range is between 3.5 to 5. So if the potassium is below 3.5, you need to replace the potassium first before starting the insulin. If they are in the normal range, 3.5 to 5, you will start the insulin, but with the insulin, you will give potassium. So you'll give potassium chloride added to the IV fluid and give the insulin, so the three of them together. If the potassium above 5, then you will start insulin and monitor closely, because remember, it will not stay above 5. Once you start the insulin will decrease the potassium. BMP is not enough. You need to get magnesium levels and phosphate levels as well, because sometimes you can see hypomagnesemia in these patients. So if the potassium below, say, 3.5, give potassium, then give insulin. 3.5 to 5, both together, potassium plus insulin together. If it's above 5, it will be just insulin. Um, Again, DKA and HHS usually complications, so look for any different type of trigger. So here, after you stabilize the patient, after you give the patient IV fluid, look at their potassium, look if you'll start insulin. After all that, you'll start to look for a possible trigger. There are possible 5 common triggers for DKA between infection. As we said, if you see a fever, you have to suspect an infection. Sometimes they cannot afford the insulin, or they're not taking the insulin, so insulin omission, sometimes infarction, intoxication, and iatrogenic. Um, SGLT2 inhibitors become now more common in diabetic patients with, provided benefit, cardiovascular benefit. So now PCPs and cardiologists tend to prescribe more SGLT2 inhibitors. So now euglycemic decay become more common. So just if the glucose is normal, don't just exclude DKA. You have to get good medication history on these patients. Again, if febrile, you need to get cultures from the CNS, cultures from the urine, sputum culture, blood culture, depending on what source you are suspecting. Sometimes the trigger can be, again, we said infarction as a possible trigger. So it can be an MI. If you're suspecting an MI, you'll need to get troponin and the EKG as well. If you are suspecting pancreatitis, which can cause DKA, you can get lipase. If you are suspecting stroke, you'll get CT head. So stabilize. This is the sequence. Stabilize, give IV fluid, check potassium, replace potassium if less than 3.5, then start insulin. Please don't start insulin before checking potassium because this can cause severe hypokalemia and this can be potentially fatal. We said IV fluid will be the first thing to start with resuscitation. So I want to know which fluid to choose, how much exactly fluid to give, and what modifications we can give to modify the IV fluid according to the potassium and the glucose. So the fluid of choice, is it normal saline or lactate ringer? LR, now there's some studies suggested that LR can be better than normal saline, but historically and most of the different protocols, they still use normal saline. So zero point 0.9 normal saline usually is the first line. If there is hyperchloremic metabolic acidosis, in that case you can switch to LR. So NS, it's cheaper, universal availability, it's always available. So you can always start with it in case of shock. NS, it's only sodium and chloride. It doesn't have any potassium, so it's safe in hyperkalemic state versus LR that has some potassium in it that can worsen um, um, hyperkalemia. The benefit in LR, it's more physiologically balanced, so it will not cause the hyperchloremic acidosis. And again, some RCTs prefer LR. The downsides of LR is mainly it has potassium. So if the patient is already hyperkalemic and you give them um, LR, that can worsen the potassium or the hyperkalemia. So in the IV fluid resuscitation, there is usually 4 phases. Phase number 1 is the first hour. Phase number 2, from the first hour to 4 hours. Phase 3 starts when the glucose drops more less than 250, and phase 4 is usually the resolution. In phase 1, you want to start IV fluid. Larry, I don't care whether it's NS, whether it's LR, just start on something. After you give the potassium, if you see the potassium is high, you should avoid LR. But usually just start with NS, that's fine. Rate, initially you'll give bolus, then you'll do maintenance. How much bolus exactly? You'll give 1 liter over 30 to 60 minutes, and this is mainly hemodynamic stabilization. This is the very most important point to do in the whole resuscitation. Phase number 2, um, you can drop the NS to 0.45 sodium chloride instead of NS. And here, usually the patient start to be hypokalemic, or if you start insulin, they can be hypokalemic, or if their potassium between 3.5 to 5, you can give some potassium chloride added to the IV fluid. And the rate here will be 250 to 500 cc per hour. So this is the maintenance. So phase 1 was mainly the bolus phase. Phase 2 is the maintenance phase. And here, your goal in phase 1, your goal was stabilization. Bolus stabilize, maintenance doesn't stabilize. So if you want to stabilize someone, you have to bolus. Phase number two is not about stabilization, it's mainly to correct the dehydration, and if there is hypokalemia, you correct the potassium in this phase. Phase three, usually after the starting the insulin, you start to see drop in the potassium. Drop in the glucose. And in this phase, phase three, when you start thinking about adding some dextrose. So you can add D5W with the chloride and potassium chloride and the NaCl. And the rate here will be even slower. So here's 250 to 500. Here the rate will be 150 to 250 cc per hour. And your goal here in phase three, first, is to prevent hypoglycemia. Try to avoid hypoglycemia because it's bad prognostic marker in DKA and HHS. So we're trying to avoid hypoglycemia. That's why we added the D5W, but also keep the flow going because we want to clear the ketones. So here it was mainly IV fluid bolus just for maintenance. Here we are treating the dehydration and we're giving some potassium, so IV fluid plus potassium. Here we're giving the IV fluid plus potassium plus some dextrose to avoid the hypoglycemia, and usually the glucose drops below 250 in this phase. So we stabilized, we treated the dehydration first and the potassium, and here we are trying to avoid the hypoglycemia and clear the ketones. Phase four, it's almost the resolution phase. Here we can just keep the patient on D5W if they are not eating. If the patient is eating, we can just rely on oral fluid. And right here, we are trying to wean off on the IV fluid and resume the PO. Remember, before stopping the IV fluid, you need to start oral feeding. So here, the patient starting having less nausea, less vomiting, less abdominal pain, so they will be tolerating oral diet, and at this point, the ketones will be cleared as well. Some special population that you need to be aware of, like CHF and CKD, those patients can be volume overloaded. Of course, if it's CKD stage 1 or CHF and it's compensated, you can be more free or liberal with the IV fluid. But if they are decompensated somehow or they have any signs or symptoms of volume overload, you need to be very cautious with fluid. So instead of 500 cc per hour, you can just do 250. Instead of the bolus of 1 liter, you can give just 500 cc. In elder population with HHS, it's the same as hyponatremia. Hyponatremia, we don't correct it very fast, or even hypernatremia. Same concept because of the osmotic effect of the glucose. You don't want to slow or reduce the glucose very rapidly. I'll not talk about the pediatrics part because I'm an internist, of course. Um, so we talked about the IV fluid. Briefly, we talked about the potassium as well, but let's just talk about it very briefly. Again, check potassium before starting insulin, and this is non-negotiable. There is no case in the world you give insulin before checking the potassium. Again, give IV fluid blindly. You don't need to check for anything. Just give IV fluid to start with. Then you start to check the BMP and the potassium before giving the insulin. So DKA causes total body potassium depletion. Why? Because we said in DKA you have acidosis, right? So you have increase in the hydrogen ions. Then you have here, this is the cell, and the cell has a lot of potassium in it. Actually, most of the potassium is in our body is intracellular. So what happens is with this acidosis and increase in the hydrogen ion, it gets into the cell. So it causes intracellular acidosis. And in exchange with the hydrogen ion, the potassium goes out. So you come and check BMP and you look at the potassium and it's 6.7. Yeah, they are hyperkalemic, but actually this potassium is coming from inside the cell. There is shift of the potassium from the cell So even if they are hyperkalemic, usually they are totally, their total body is potassium depleted. And this is really important concept. So we're checking the potassium. We have different scenarios. The first scenario, the potassium will be more than 5.5, which is above the normal range. So this is hyperkalemia. In this case, we'll not start potassium. Of course, we'll start insulin, and this will lower the potassium. And at this point, you don't give any potassium supplementation. You keep monitoring the potassium every 1 hour. In this case, NS will be better than LR because NS doesn't have any potassium, but LR it has potassium. So in this case, avoid the LR and we'll use the zero point 0.9 NS. And again, if it's severe hyperkalemia, we need to get ECG also to monitor for any ECG changes or hyperkalemic changes. The second scenario will be potassium between 3.5 to 5.5. This is normocalemic. Here, you will give the insulin and the potassium supplement simultaneously. So here you give only insulin. Here you will give insulin with potassium. So you'll give potassium chloride 20 or 40, and you'll add this to IV fluid, and you will start the insulin concurrently. Keep checking the potassium every 2 hours and target serum potassium between 4 to 5. Um, you don't have to give IV potassium. If the patient is tolerating oral diet, you can just give oral potassium. And again, even if the potassium now is normal, but you are given insulin, so the potassium will drop, so keep monitoring for that. The third scenario, you check the potassium and it's between 3 to 3.5. So this is hypokalemia, but it's mild hypokalemia. In this case, we will hold on insulin and replete the potassium first. To replete the potassium, you can give IV or oral. IV potassium chloride 20 to 40 milliequivalent per hour via infusion. And again, 20-40 per hour, we don't bolus the potassium. And we'll keep checking the potassium after each 20 milliequivalent. And when to start the insulin, again, here, when it becomes in this range, 3.5 to 5. So when the potassium above 3.5, you will start the insulin. Um, and if you are given IV potassium, this can, if you correct very fast, that can increase the risk of arrhythmias. So this patient will need cardiac monitoring. And the maximum preferred IV dose will be 10 per hour. 10 per hour. If we have severe hypokalemia, which means potassium below 3, at this point, you hold insulin. You cannot give insulin in this case. You have to correct the potassium more aggressively before giving any insulin. So here actually you can give higher doses of potassium chloride, like 40, because this is severe. Yeah, pushing too much potassium can cause arrhythmia, but if they also having severe hypokalemia, that can increase the risk of of arrhythmias. So here you are more aggressive with the potassium replacement, and usually you will need central line. So if you are given smaller doses of potassium, like 10 milliequivalent per hour, you can push a lot of fluid with that through the peripheral IV. But if it's higher doses, you'll need central line for that. And again, you'll need continuous cardiac monitor. You'll check the potassium here just because it's more severe hypokalemia, so you'll check it more often. So check it every 30 to 60 minutes. Um, Sometimes they have hypomagnesemia, so you need to address the hypomagnesemia and correct the magnesium with the potassium, because if you have hypomagnesemia, no matter you replete the potassium, you will end up with refractory hypokalemia. So you need to replete or replace the magnesium as well. And again, the same rule, only start insulin when the potassium is above 3.5. To replace potassium, you have two ways, IV versus oral. So, of course, if the patient is not tolerating oral, you have to give IV, but usually oral is preferred if the patient is tolerating. If there's severe hypokalemia or you are suspecting any arrhythmia that's caused by the hypokalemia, then IV fluid, IV potassium will be much preferred. There's two different forms of IV potassium commonly used, whether the potassium chloride, which I usually go for, and this is usually 10 to 40 milli equivalent. You run it with a lot of fluid. If you are on the 40 range, you'll need central line for that. The other form of IV potassium will be potassium phosphate. I only use the potassium phosphate if they are also hypophosphatemic. So if you have hypokalemia, hypophosphatemia, usually I go for the potassium phosphate because it will replete both. So again, let's go through this word by word. IV potassium chloride, if you are not tolerating oral or there is severe hypokalemia. So if you have severe hypokalemia below 3, you need rapid replacement so you can give IV. Maximum preferred dose will be 10 per hour. If you are increasing to 40 milliequivalent per hour, you will need central access. Again, if the patient is tolerating oral and is not severe hypokalemia, then oral potassium will be preferred. Insulin. So before we used to give IV bolus of insulin, then give the maintenance. Now you can just do the maintenance. It has to be IV insulin though. If there is mild to moderate DKA, there's now some data says that subcutaneous insulin is acceptable. And again, while giving the insulin, we are checking for correction of the ketosis with serial beta hydroxybutyrate. So we'll give IV insulin, continuous infusion, no bolus. We can give subcutaneous insulin if it's mild DKA and go back to the criteria when we um, differentiated DKA, mild or moderate or severe, according to the symptoms and according to the acidosis. So IV insulin will be preferred without bolus in moderate to severe DKA. Mild to moderate, you can use subcutaneous insulin. Again, we'll not start the insulin before checking the potassium. So if you are giving insulin, the potassium has to be at least above 3.5. So how much insulin? So if we are given IV insulin, we will use regular insulin and it will be maintenance. So there is no bolus. How much exactly to give? It will be zero point 0.1 units per kilogram per hour. Um, if there's mild DKA, so subcutaneous will be accepted, but you have to give rapid acting, like Lispro. You don't want to give glargine, that's very slow. You want something fast, and the dose here will be initially zero point 0.3 unit per kilogram. That's one time. Then after that, you can give zero point 0.1 unit per kilogram per hour subcutaneous. Again, the bolus is not now recommended because it didn't show any benefit and can increase the risk of hypoglycemia. While running the IV fluid, the insulin, the potassium, everything, there is some few labs that we regularly check. First, the glucose. We check the glucose hourly. You don't need BMP for that. You can, or lab glucose, you can just do bedside glucometer. And the target drop of the glucose will be to drop the glucose 50 to 75 points per hour. Again, we'll get serial beta hydroxybutyrate every 2 to 4 hours, and the goal is beta hydroxybutyrate below 1. Remember, in DK, it's usually above 3, so you are trying to get it down from 3 to at least 1. If glucose drops less than 50 per hour, so the normal or the expected will be 50 to 75. So if it's below 50, that means you are dropping the glucose less than expected. So in this case, you can adjust the fluid rate and also the insulin rate. Um, Beta hydroxybutyrate is more reliable than the anion gap to track ketone clearance because this is just direct. You are checking the ketones directly instead of checking the anion gap and the acidosis part. And don't stop insulin based on glucose alone. You need glucose to be cleared and the ketosis and the acidosis to be cleared. Can you stop the insulin if there's an ion gap? Yes. So if you cleared or got the glucose to the 200 range and you corrected the ketosis and the acidosis, yes, you can stop the insulin even if there is some anion gap still. Let's talk about the glucose. When they are in DKA, we need to target blood glucose below 250. Um, but when it drops below 250, and if the DKA is not resolved yet, and you still need to give the insulin for the acidosis, we are not giving the insulin here for the hyperglycemia, we are giving the insulin for the acidosis, and you have to continue giving the insulin if the acidosis didn't resolve. But the problem is if the glucose drop below 250, in that case, you'll need to add D5W to the IV fluid. In that case, also, once the glucose drops below 250, we drop the insulin rate. So instead, we drop it by 50%. So instead, zero point 0.1 unit per kilogram per hour, we drop it to 0.05. And we are maintaining the insulin here, not for the glucose. We are maintaining it till the ketones clear. Um, the target glucose between 150 to 200 until DKA resolution. And again, will not stop the insulin even if the glucose went down because we are treating the ketosis, not the hyperglycemia here. When to transition to subcutaneous insulin? So we'll transition from IV insulin to subcutaneous when there is resolution. So you got the glucose down, you got the ketosis cleared, and the acidosis resolved. So the DKA has to be resolved, and the patient is eating already. Because if you switch and the patient is not eating and you stop the IV fluid with the dextrose, they can get hypoglycemic. So we'll give subcutaneous basal insulin, then wait 1-2 hours before stopping IV insulin. So there has to be an overlap between the IV insulin and subcutaneous basal insulin. So you give subcutaneous insulin, the basal subcutaneous, make sure the patient is eating 1 or 2 hours after you stop the IV insulin. So there has to be 1 to 2 hour overlap to prevent any rebound ketosis. So these patients need the insulin to be in their system continuously. Because what happens if you give IV insulin, then you stop it, and you give now subcutaneous insulin. So this subcutaneous will not work right away. It will start working or maximize maybe after 1 or 2 hours. So you don't want to leave the patient 1 or 2 hours without insulin. So they have to have some continuous insulin in their body, whether from the IV or subcutaneous. Um, the acidosis and the electrolyte management. Sodium bicarb there's some controversy about sodium bicarb, but usually you can consider it in severe acidosis if pH below 6.9. If it's between 6.9 to 7, you can consider like an ampoule or two of sodium bicarb. Um, Sorry, if it's above 6.9, we don't give bicarb because this is not severe. If it's below 6.9, we give bicarb. If it's between 6.9 to 7, we can consider an ampoule of bicarb. And I'll not go through the details of the sodium bicarb. That's all what you need to know. When to consider intubation if they cannot compensate or they have altermentation with GCS below 8. So here you are trying to protect the airway because they can lose their airway if the GCS below 8. Sometimes they can be fatigued because with the increase in the respiratory rate to compensate for the acidosis, this they can have some kind of like respiratory fatigue, and that can worsen the compensation. But remember, if you decide to intubate, those patients will be very high risk for intubation because with the sedation, with the neuromuscular blocker, you will um, put a hold on the compensation that they usually trying to do by themselves. And if you decided to intubate, you have to ventilate and even hyperventilate to decrease the PCO2 to try to match the pre-intubation PCO2, or if you want to calculate the Winter's formula to try to target a specific range of PCO2. Um, Some other electrolyte abnormalities between phosphate and magnesium. So we get BMP and magnesium and phosphate as well, not just BMP, because DKA can cause phosphate depletion. If they are phosphate depleted, as I said before, you can give potassium phosphate instead of potassium chloride. So in this situation, you need to replace the phosphate with the potassium. If they're having a hypomagnesemia, this can cause refractory hypokalemia. So no matter, despite the potassium replacement you are trying to make, they will not correct the hypokalemia. So you need to correct the hypomagnesemia to correct the hypokalemia. Some differences between the HHS and DKA management. DKA usually they are less dehydrated, so they are having fluid deficit between 3 to 6 liter. In HHS, they usually have 9 to 12 liter deficit. So HHX usually much more longer. We said it's usually days to weeks, slower onset, so they are severely dehydrated. So here you need to give them higher level of IV fluid than the DKA. NS still a good choice for both DKA and HHS, but because of HHS, they have already hyper osmolality, and with the zero point 0.9 normal saline, that can increase the osmolality as well. So sometimes you need to switch to more hypotonic because, again, those patients have a lot of hypertonic glycemic state. Insulin is more necessary in the potassium and DKA, but again, we only start after potassium correction. In HHS, sometimes if you give just fluid, that can drop the glucose without even need to give insulin. In most cases, yeah, you can give insulin, but just give a lot of IV fluid and see how the glucose drop, because sometimes you can just avoid the insulin. So IV fluid alone may reduce the glucose 100 to 200 point in HHS. In DKA, you are targeting glucose between 150 to 200 until DKA resolved. In HHS, it's usually 200 to 300 because you don't want to overcorrect very suddenly, because this can affect the brain as well. But also remember that the range of hyperglycemia in HHS is way higher. So here you are starting with glucose usually above 600, but here you are starting with glucose above 200. So in HHS, we don't lower the glucose too fast because this can increase the risk of brain edema. Sodium correction, we sometimes need to correct the sodium here. Here, we don't need to um, correct the sodium if it's 10 to 12 points, because just given IV fluid, especially the hypotonic, will um, correct the the sodium, but also both glucose and sodium, they are hypertonic, they hyperosmolar. So if you are reducing or trying to decrease the glucose and the sodium at the same time, rapid correction that can cause central pontine myelinolysis. You have a ketone target in the DKA. You are trying to decrease the BHB below 1. You are not worried about the ketones or the acidosis in HHS, right? Um, The insulin dose also differs in DKA and HHS. In DKA, usually you're not given a bolus, you're given maintenance of IV regular insulin, zero point 0.1 unit per kilogram per hour. In HHS, you can give the same rate, but sometimes lower doses can be efficient, so you can give half the dose of that, which is 0.05. So that's one thing. DVT prophylaxis will be important in DKA and HHS, but it has higher priority in HHS because those patients having hyperviscosity increases the thrombosis risk. So you need subcutaneous heparin or subcutaneous Lovenox. Usually, mental status in DKA clears with treatment, but HHS, but just because of the process, it's a slow process, and usually the CNS recovery will be slow. So IV fluid, usually it can be triggered fast, can start very fast, but also get treated fast, and the symptoms go faster. While in HHS, it grows over time, over days or weeks, and cause the CNS depression, and when you correct it, you need longer time to correct it, more IV fluid to correct it, and also you don't expect the symptoms to be cleared very fast. Usually a more slow process even in the recovery. So, key principle here about the differences between HHS and DKA. HHS will require more fluid, it will correct slower, it will require lower insulin doses. Sometimes because they are severely dehydrated, they can be hypernatremic as well, and they can be severely hypernatremic. So you'll need to take care of the sodium as well and correct that with hypotonic saline or any water, free water to correct the hypernatremia. And in HHS, they will need aggressive DVT prophylaxis. Thank you for watching the two videos.